Welcome, everyone. Good evening, and welcome to JFSA's Brain Health and Wellness Initiative series, where we bring community education each month to inform and promote a broad landscape for brain health. We offer CEUs to our professional audience as well. I'm just going to go ahead and share my screen. Sorry, just be a second. All right. So today's topic is the origins and demographics of dementia, presented by Dr. Dennis Grossman. My name is Jonathan Yasani, and along with my colleague Hannah Thompson, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia or are at risk of developing dementia, while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients' strengths and applying a person-centered approach to care, which extends throughout our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Hannah and I meet our clients where they are at, and develop individualized care plans that help produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management, we are their point of contact for guidance, a listening ear, and creating interventions that adhere to their biopsychosocial needs and experiences. I would like to just point out here, like during the presentation, we have our Q&A button here on the Zoom webinar system. Go ahead and type your question in the Q&A box, and it's just as things come up, you can go ahead, jot that down, and we will go ahead and have a question and answer section afterwards. Dr. Grossman, a graduate of Case Western Reserve University School of Medicine with over 30 years experience in internal medicine, has been on the staff of University Hospitals Bedford and Ahuja Medical Centers, Cleveland Clinic South Point and Marymount Hospitals, Metro Health Medical Center, and he is the current medical director at JFSA and a clinical instructor at the Case Western Reserve School of Medicine. Dr. Grossman has served as chairman of medicine and chief of staff at UH Bedford Medical Center. He has had affiliations with several nursing homes where he followed his patients after their discharge from hospital stays. He offers continuity of care and values the personal relationships with patients by following them over time with continuous monitoring to ensure positive health outcomes. For the past 30 years, Dr. Grossman has been interested in the effects of diet on chronic Western diseases and promoted plant-based diets and macrobiotic diets. Dr. Grossman believes that they play a key component in preventing and reversing some types of diabetes, hypertension, heart disease, stroke, and degenerative joint disease. Without further ado, here is Dr. Grossman.
Thank you, Jonathan. And it's an honor and pleasure to be here this evening in this temperate zone of Cleveland, Ohio. So my topic tonight, origins and demographics of dementia. I thought I'd go about the presentation a little differently. I wanted to throw out a whole bunch of information or facts in terms of demographics, not draw any conclusions, but just have people look at the demographic facts and see what their questions are, and then touch on a little bit about newer concepts in terms of the origins of dementia. And then lastly, I wrote down a few questions just to kind of tease the audience and see what your thoughts are, what it conjures up in you. So first, let's see. So we do know that there are genetic predispositions for dementia, but genes are really just the framework, and they do increase the likelihood of dementia, but they are not always expressed. Epigenetics is the field of how our environmental stressors, how our lifestyle can impact the expression of various genes. One of the things we do know, if you were to list the top two causes of dementia, vascular disease and Alzheimer's would come to mind first. And actually, they are in some ways intertwined. Vascular damage to the brain is a situation where the blood flow is either interrupted or there are some damaged areas due to narrowing or blood clots. It can be due to hypertension, to plaque formation in the arteries, or it can be due to heart disease itself. In addition, inflammatory diseases are also a factor in terms of dementia. And those inflammatory diseases, the most prevalent are obesity, diabetes, and the autoimmune diseases, degenerative diseases. And then lastly, and I'm going to touch on this later, the microbiome of the mouth and intestine and the setting up of infections that can damage the brain is a third way that we see damage to the brain and dementia following it. And that's one of the topics that's a little bit newer, and I'm going to go over that near the end. So we do know also that there are a myriad of other lesser known reasons why dementia occurs. Trauma to the head, obviously, with damage. Toxicity in terms of heavy metals, copper, aluminum, iron, and nutritional deficiencies. And one of the more prominent ones, of course, in alcoholics, thiamine deficiency, but there's also B12 deficiency and folate deficiency. I'm listing about 20 areas that I'm going to give you demographics on. And here's where it's going to be sort of, it's a Jackson Pollock painting. I'm going to throw stuff on the floor, and you're going to look at it and see if it's a worthy paint job or not. So we're going to talk about age, sex, education, ethnicity, disease states, socioeconomic status, urban versus rural, country, geography, birth weight, body size, habits, depression, occupation, age of retirement, night work, shift work, sleep history, marital status, diet, exercise, vitamins, and supplements. That's a whole lot. So get ready to digest this. Age and dementia. So we know that the older you get, the higher the percentage that we find of dementia in the population. And some of this, again, is common sense, but we do know that many processes increase as you age. So dementia just may be a reflection of some of these other processes catching up with you as you get older. Men and women, again, male versus female, but we have to understand that women live longer than men. So that's 16% versus 10%. Is that a product of being a female, or is that a product of being older in the female population, the average age? One thing they have looked at is estrogen and lack of estrogen. And actually, in some ways, estrogen is supposedly protective against dementia. So the number of years without estrogen through menopause may be a factor there. Education. Finished college, some college, finished high school, did not finish high school. So if you were to look at that just straight on, you'd think, well, you're 3 times as likely to get dementia because you did not finish high school. On the other hand, it may be that your life expectancy and your habits and a lot of other things are different for those people that didn't finish high school. So again, statistics may be a little bit deceptive. Oh, and I guess I did write down there, wealth may be a factor in educational attainment. So race and ethnicity. And this kind of was interesting because highest rate, African Americans, Native Americans, and it goes down until you get to Pacific Islanders. Again, this may have to do with a myriad of factors, not just ethnicity, but it may have to do with age, education, stresses, things like that. So we do know that disease processes affect dementia. So vascular disease, hypertension, diabetes, obesity, all show an increased rate of dementia in those disease processes. Socioeconomic status. And the worse the socioeconomic status, especially early in life, will increase the rates of dementia later in life. It's also, they think, a factor in terms of the racial disparity of dementia as it develops later in life. So again, these are factors that are somewhat intertwined. Urban versus rural. So people in urban settings tend to have a lesser degree of dementia. On the other hand, differences could be due to education, socioeconomic status, work history, age, things like that. Now, this is a tough slide, but I wanted to throw it in anyway because of the huge discrepancy. You sort of have to sit on your, well, lay down on your side to read this, but if you lived in Turkey, your rate of dementia per 100,000 is 57. If you lived in Bulgaria, and I can't really read this, but it's around 2. So that's about a 25 times difference in terms of those two countries. And you can look at it all the way through, and there's the United States at 32, pretty high. United Kingdom, Finland. So you look at this and you try, and as humans, we always try to make sense of statistics, and I've got to get this pattern, and I'm thinking, well, where's the pattern here? Is it cold climates, more developed climates? It's all over the place. So, just looking at this, I think is mind-boggling and almost an exercise in futility to figure out what it is that contributes to dementia. Educational status, wealth, warm climates, cold climates, you name it. So they're all mixed in here. Low birth rate, short stature. People who are shorter tend to have an increased risk of dementia. So what does that mean? I don't know. I think it means nothing except that maybe low birth rate is a reflection of the socioeconomic status, the nutritional status early on in life. Again, all these are factors that are not independent, but they're just some demographics that I throw out there for you to kind of look at and manipulate. Waist circumference. So obesity in midlife is correlated with dementia, and height is inversely related to dementia. Obesity is an inflammatory disease. We've found that out in the last 10 years. So we know that inflammation in the form of either obesity, cardiovascular disease, or diabetes is going to increase the inflammatory response throughout the body and create a predisposition for more dementia. Smoking and alcohol consumption also increased risk of dementia. Caffeine is correlated with a decreased risk of dementia. Again, I don't know, again, these are statistics. What they mean, I leave it up to the audience to figure that out. Depression. So it's, in some cases, we see that depression precedes dementia, and that in dementia, there is a component of depression, and it is actually hard sometimes to differentiate people who are truly depressed versus beginning the early stages of dementia. There's some very similar presentations and symptoms, and sometimes the work of the gerontologist is to tease that out and figure it out. But there's approximately a twofold increase in the risk of developing dementia with long-term depression. Physical work, and I couldn't figure this out, but it's actually associated with an increased risk of dementia. That may have to do with socioeconomical, educational, because again, people that are doing physical work probably have less education, less means, and they may be in a lower socioeconomic class. Verbal and social skills usage at work associated with this decreased risk. So those people that work in areas where they're communicating a lot, where they are interacting with others and using their verbal skills is a factor in decreasing their risk for developing dementia. Age of retirement. So that's why I keep putting off retirement. But anyway, it is correlated with a decreased risk of dementia. Later the retirement age, the less the risk of dementia. And I think that's somewhat obvious because obviously you are engaging more with other people. You are doing tasks that may stretch your brain and make you utilize skills that once you retire, you walk away from. Night shift workers, especially those who undertake night shift work in middle age, are more likely to develop dementia. I found this fascinating, and actually we've seen that working at night creates a stressor in terms of the body and the immune system. And so some of this may be related to stress factors and inflammatory type stress factors in the body through an abnormal pattern of sleep, a pattern that is not in sync with the light and dark cycle of the everyday world. And this also sort of leads into sleep deprivation, which night shift workers and actually swing shift workers develop this at a much higher rate. Also sleep apnea, which causes sleep disturbance and which causes hypoxia, both are correlated with increased risk of dementia. And the hypoxia, again, if you think about it, the brain obviously needs a lot of oxygen. It's 4% of the body weight. It utilizes 20% of the fuel and oxygen in the body. So being married is associated with a reduced risk of dementia when compared to never being married, divorced, or widowed individuals. So there you go. Got one thing going for you. So, and I think some of this is pretty straightforward. A lot of this probably has to do with social interactions and possibly socioeconomical situations, but a lot of it, I think, is social interactions, increasing those, especially people that have been never married, who then tend to have less interactions with other people. It's more pronounced in men and only a slight impact on women, because I guess women are more social, or maybe women don't need men to socialize and men need women, I'm not sure. But anyway, you can draw your own conclusions from that. Vegetarians have a 38% decreased risk of dementia when compared to non-vegetarians, even after adjusting for all these other things. So maybe there's something to be said about diet in terms of developing dementia. We do know that vegetarians tend to have a lower state of inflammation in the body, and that may indirectly correlate with decreased risk of dementia as they get older. Exercise. So the more exercise, the increased usage of oxygen, ability to use oxygen, and it also improves the blood flow. It increases something called brain-derived neurotropic factors, which increases neuronal growth and synaptic activity, which are the main sources of communication within the brain. Cognitive and socially engaging activities in midlife reduces the incidence of dementia. So line dancing, I guess, is what this is supposed to be, or else it's the Rockettes. So it actually, there was a study in identical male twins, and it proved that there was less of a chance of dementia in the twin that did more social and cognitive engaging activities. We also know that beta carotene, vitamin C, improve the cognitive ability, or decrease the likelihood of getting dementia, although very small. Vitamin D deficiency has been correlated with cognitive impairment, and elevated homocysteine levels. And homocysteine, so when somebody has a vitamin B12 deficiency, they develop elevated homocysteine levels. So indirectly, this is really a marker of vitamin B12 deficiency. As I said before, infection and inflammation, the vascular disease, vascular dementia, Alzheimer's disease, these are all a consequence of a inflammation, but the question is it also a consequence of an infectious process? And this is some of the newer data that's come out in the last few years. And it goes back to, if you go way back, several diseases that are infectious have caused dementia. So syphilis is one. Syphilis is an infectious agent, which is a spirochete, somewhat of a bacterial type of infection. Mad cow disease, which was a form of Creutzfeldt-Jakob disease. It's a viral disease that also causes dementia, usually in younger people. AIDS. AIDS created a cause of dementia before it was recognized and treated. Again, a virus. So there is, albeit very small, a history in the past of some infections causing dementia. So what about now? Well, there have been some very elaborate studies that have shown that some of the damages in the brain, especially attributed to Alzheimer's disease and the amyloid formation and deposition, may indeed not really be the cause of dementia, but actually be the body's response to a bacterial infection or some type of foreign infection. And how does that happen? Well, we have to go back to our defense mechanisms. Throughout our gastrointestinal tract, from the mouth all the way down to the rear end, we have bacteria in there, lots of bacteria, and they actually form a protective barrier throughout this gastrointestinal tract. And the friendly bacteria actually create what's called a bacterial film, biofilm, which lines the entire tract from the mouth all the way down. And that prevents bad bacteria from actually penetrating in through the cells of the gut and actually into the bloodstream. So it's important that we keep these biofilms intact, and they are enhanced by having a diverse microbiome, a healthy microbiome, bacteria throughout the gut. Dysbiosis is a term used when we see that there is a paucity of types of bacteria and that they're not so friendly. They're not the kind that actually promote and protect this biofilm. And once that happens, once you change the bacterial lining, it can lead to damage to the barrier and then migration of the pathogenic bacteria or viruses into the bloodstream. And one of the most important things in the diet that maintains the biodiversity and the healthy biofilm is the amount of fiber in your diet. And the average American diet has about 20 grams of fiber. If you actually compare that to more primitive cultures, their amount of fiber is more like 100 grams a day. So we have changed our diet in many ways, but the biggest way is that we have replaced fiber with foods that have been somehow altered and processed, I guess is the right word. But going even further into this in a little finer area is the mouth. What they found is that gum disease itself and tooth decay may be implicated in several illnesses: cardiovascular disease, vascular dementia, and Alzheimer's disease. There's a bacteria called, and I don't know if I can pronounce this, Porphyromonas gingivalis, and Borrelia, which is actually the culprit in Lyme disease, and some other bacteria are found in the blood vessel and brains of dementia patients and heart patients. These bacteria cause the body's defense mechanisms to actually attack the bacteria, and they may then form these amyloid plaques and these arterial plaques in the blood vessels as a protective device. So what we're looking at as the culprits may actually be the body's only way of trying to fight what's going on. So the gum is really the gingiva is really the important area where bacteria enter the bloodstream. And P. gingivalis actually creates its own biofilm, which is called plaque, which I think we've all known about it. And this is wrong. Oh, I'm sorry. Would decrease the biofilm. This is an error. And this biofilm, which is there, increases the bacteria's resistance to the body's immune system by 500-fold. I'm saying this right. This is biofilm. Oh, I'm sorry. If you have an intact biofilm, your body's ability to resist bacterial entering is increased by 500-fold. It's also this biofilm. I'm sorry. I apologize. I've got this backwards. The biofilm that P. gingivitis makes is not a good biofilm. That biofilm actually enhances that bacteria's resistance to our own immune system by 500-fold. And that biofilm also is increased, that bad biofilm, so there's good and bad biofilms. That bad biofilm is increased with elevated iron levels, with elevated homocysteine levels, arginine levels, and low vitamin B levels. So you've got good biofilms and bad biofilms. This just happens to be a bad biofilm that this bacteria is able to create and cause significant damage and entry of bacteria into the bloodstream. So I throw that out as kind of a newer theory about what causes some dementia. Obviously, it's not the whole story. There's many reasons why we have dementia, and obviously, heredity is a big part of it. But what I wanted to throw out were some questions for people to kind of think about. What were the most unexpected statistics? Which ones sort of jumped out at you and you thought, oh, that can't possibly be, or what's the reasoning for that? What were the most predictable ones? Which ones were sort of no-brainers? And how do we explain the vast discrepancies in all these countries' rates? I mean, 25-fold discrepancies. How do we protect ourselves from bacterial agents? What role does oral hygiene play? And does diet contribute to the problem? And lastly, a couple of questions. So where do we best put our limited healthcare dollars in addressing dementia? How do we address inequities among groups, those that are higher risk for dementia? And what institutions help? Which institutions hinder the progress in this area? And can we look for best practices in ethnic groups or other cultures to guide us? You know, do we look to other countries? Do we look to other ways of tackling this problem? Questions? Those are my questions. Now we're looking for your questions. Thank you.
Thank you, Dr. Grossman. So if anyone has any questions or would like to answer some of Dr. Grossman's questions, or have any insight or just some comments about the presentation today, go ahead and go to the Q&A and leave a message for us and we will address that. In the meantime, I do want to go back, and I had a couple questions for Dr. Grossman about the presentation, just some of his questions that I wanted to run past. And it was interesting, you know, in my opinion, if we do look at different cultures and what they consume, what their lifestyle looks like, even down to like where their values lie. I think it's something to be said to take from different people and, you know, incorporate it into your daily life if, you know, you find that it can be helpful along with exercise and daily healthcare checkups. So when Dr. Grossman was talking about the different countries and statistics, looking at Turkey and then compared to Bulgaria with such a huge gap, like a huge difference in statistics, I thought that was really interesting. And I'm curious if anyone else did too. You know, our healthcare systems may play a huge role in that, especially if there's universal healthcare versus healthcare that, you know, it's really hard for someone to access. I have a question here. What is it about Singapore that is healthier? Dr. Singapore.
What is healthier about Singapore? Well, I mean, their healthcare, first of all, their standard of living is very high. They have healthcare for everybody. It's a urban setting. There's a lot of social interaction. So a lot of these factors may be part of the answer. It may have to do with family structure, a lot of socialization in terms of family, in terms of activity, in terms of their priority, maybe a very verbal culture. We do know that it's the density per square mile is very high, so a lot of interaction there. So maybe not just one specific thing, but several factors contribute to it.
Thank you. Yeah, and that really helps answer my question too, just about the differences in the countries and cultures and how it all comes about in the long run, whether we are more predisposed to dementia or not. Why do day-to-day inconsistencies arise in dementia patients? That's a good one.
So, I think dementia patients go through stages. It depends on what stage they're at. I'm probably not the expert to ask that. A gerontologist would be able to answer that better. But there certainly are factors in terms of where they're at in their dementia process that may be affecting that. So I think that's a good question, but I don't think I'm well equipped to tell you why from day to day, except to say that there's a process that they're going through, and it's not linear. It's there's ups and downs, and that may be part of the solution or the answer to the question.
Many of the factors discussed seem to have their impact to midlife. Does encouraging good habits like oral health and exercise help if the person is at a later stage in life? Another good question.
I would think so, even though, a lot of the statistics or what you've seen has to do with midlife. But I think that you can impact at any age if you are determined and you have the ability and the drive to do those things. For instance, changing your diet, being more active, being more social. These are things that, for some reason, there are benefits throughout life. And don't forget, in midlife, most people are working 40, 50 hours a week. As you get older in retirement, there may be different time constraints or loss of time constraints. And what may happen, what you can't compensate for in midlife, maybe you can compensate for later in life because you're less restricted.
It's never too late. In response, thank you. Sounds like a place I would like to live. That does sound nice, Singapore.
Singapore.
Yeah. Does anyone else have any questions? I'm going to just double check here to make sure. Oh, there's a chat. Oh, I do experience as primary care social worker many hurdles in finding affordable dental care for my patients. It seems like proper dental care should be on the top of the list as preventative healthcare services, especially given all we know about its impact on heart health.
Yes. So I would agree. I think not only is universal health care fallen short here, but dental care, the importance of dental care, I think we've realized in the past decade is very significant in terms of vascular disease, heart health, as you said, but now in dementia. And we are fooling ourselves if we say we want to promote health and yet neglect probably one of the prime areas where we can get the most bang for our buck, and that's in dental care and gum care. And for most people, it's not affordable. And it is not something that that has created a hue and cry like the healthcare, the Affordable Healthcare Act did. So I think it is important. I think you've hit a nail on the head, and hopefully we can address that.
Yes, I totally agree too. It's really unfortunate that it's a separate health plan that you have to purchase into, and it's not included in our regular medical plan for people that have medical plans. So, and it is a primary source of where infections can occur, and then, like Dr. Grossman was saying, create more issues that are even that then affect that healthcare plan that we have. So why not prevent it in the first place? Let's see if we have any more questions. Many thanks, Dr. Grossman, for a very informative and insightful presentation. Thank you for that comment. So again, I do want to state, like, if you guys have any questions that you think of later on, please do not hesitate to reach out to either Nicole, you can reach out to me, or Hannah. I will have our contact information on the next couple slides. Dr. Grossman, did you want to add anything?
No, one thing that did come up, you know, we pay for podiatrists, but we don't pay for dentists. So it just shows you where we put our money, not where our mouth is, but where our feet are. You know, and thank you. And I'm sorry if I confuse people with the biofilm. There's good and bad, and I misspoke myself. But the idea is that you know, your dental care and your oral care is paramount of importance. And I spoke to my dentist and discussed it with him, and he said, you know, you're absolutely right. On the other hand, we can't do a double-blind trial, because then we wouldn't be treating something that we know would make people worse. So hopefully you can treat yourself and just take some time and address the care of your gums and your teeth, and hopefully that will help.
Yes, and it just crossed my mind too. There's the Case Western Reserve University Dental School, and they may be a good source to reach out to. I know that here at JFSA, well, once we, you know, come out over COVID, we'll be able to get the dental band back, and they've been a really great person that we've worked with, and they've helped a lot of our clients. I think we have a couple more questions. I just want to double check here. Is aluminum foil harmful?
So I don't think so. I think it's the heating of the aluminum, and if you're as old as I am, you remember Club Aluminum Ware on the West Side. It was the heating process. So aluminum foil, unless you're heating in it, I wouldn't do that. But if you're using it just to cover, that's different than when you actually are heating aluminum and cooking stuff in it. That's, I think, where the issue was.
All right. So again, if you guys think of any more questions, please reach out to me, and I will go ahead and direct those questions to Dr. Grossman and reach back out to you. Below here, you'll see my phone number, Nicole's phone number, and Hannah's as well. I'll just leave this up for a second or two so you can jot down our information. Okay, and I do want to show you guys some information here about our two memory care specialists, Dr. O'Toole and Dr. Magulius. These two doctors are part of our dementia care navigation team. They help create care plans for our clients. We work one-on-one with them, and they are amazing doctors. They're so easy to contact, and they are willing to take phone calls after hours from us to be sure that the next day their clients and their patients and our clients are able to get the care they need. And here's Nicole's information. And we also have Leanne Stuber. She's our facilitator for our online Zoom support group and our Savvy Caregiver program. And she also she's an instructor, educator, but she also completes these presentations for our Brain Health and Wellness Initiative series. And our upcoming live webinar is going to be about physical activity and brain health presented by Leanne, and that's going to be Thursday, May 27th between 6:30 and 7:30. If you'd like any information about it or would like to register, please reach out to Nicole Herbert Hale at 216-903-1189. And I want to thank you all for joining us this evening, and I hope you have a great night. Thank you.